The ventricle squeezes, this door opens to eject the blood. But what if that door doesn't stay closed? Then what will happen? Mitral regurgitation or mitral insufficiency. Anybody want to predict? So what are the pressure volume relationship that will happen if this door opens instead of staying closed when the ventricle contracts? What are the issues that you'll have here with preload and afterload and contractility? Preload will increase. Yep. Does anybody know why preload would increase?
Because there is additional amount of volume that's found in the left atrium that's additional coming.
Correct.
Left ventricle on the next side, correct.
So the blood that we're ejecting, instead of it going forward and not being available to fill the ventricle again, now it went back. And so now with each cycle, there's more blood coming in. So overall volume goes up. So you have an increase in preload. What will happen to afterload if this door opens? When only that door is supposed to open, if this door also opens, what will happen to afterload? Afterload will decrease. So the ventricle has to fight less pressure because on this side, we have our body blood pressure, or systemic blood pressure of 125 over 80, okay? On this side, we only have atrial pressure. So what's typical atrial pressure going to be for a healthy person? 15, 10, 15 maximum. So normally you have to fight a mean arterial pressure of 65, 70, and now you have a mean atrial pressure that's 10 to 15. So you effectively reduced your afterload. The ventricle has to fight less pressure. So what will happen to stroke volume? We said that the preload was going to go up, the afterload is going to go down. So what's going to happen with the overall stroke volume? Preload went up, afterload went down. So what will happen to stroke volume? Increase, right? So the mitral valve situation, this is a much more accurate representation of what I'm talking about. So this is the aortic valve, that's this door. This is the mitral valve, that's this door. So in this situation, when the ventricle ejects blood, it's supposed to eject blood through this door. But in our patient situation, the blood is being ejected through both doors, okay? So that means a reduction in both afterload and an increase in preload. So what you see here is the left ventricular end diastolic volume went from here to here, so the preload went up. The afterload went from here to here, it went down. So again, the stroke volume in this patient increased. And it's going to be the exact same problem. So what are the typical clinical situations where you will detect a patient with mitral regurgitation? When they come to the office to see a doctor, what are the types of things that you may... Yeah, so would that be something that you see early in somebody's history or late, right? So it's the same problem that I mentioned for aortic insufficiency. These patients have an increase in their stroke volume. So they're very immune to symptoms. They generally don't have symptoms. They generally feel well. But if you allow this to continue over time, this increase in stroke volume, increase in preload, decrease in afterload, over time this actin-myosin relationship will become like this, and they will dilate their left ventricle. Once they dilate their left ventricle, it is often very difficult to reverse. And it's the same problem. It has to be detected and corrected before the patient has dyspnea, before the patient has atrial fibrillation, before they have an arrhythmia. Because once they start to have these problems, it often is not really helpful to correct the leak anymore. So it's a very different problem that has to be identified and dealt with before the patient develops these symptoms. Does that make sense what I'm saying? So then the last scenario that I want to talk about is this door functions properly. This door open properly, okay? And that's another type of problem with the mitral valve. What would that be if this door doesn't open properly? Mitral stenosis. I kind of gave you the clue at the bottom of the screen there. But, so what are medical issues that can predispose a patient to mitral stenosis? Rheumatic fever, that's the most common probably in the world. I don't know that that's necessarily a very common problem in Western Europe, but certainly in South America and from my part of the world in South Asia, it's a very, very common problem with patients who've had streptococcal infection without adequate antibiotic treatment. They will develop rheumatic heart disease, and that can affect the overall functionality of the valve over time. And mitral stenosis is a very, very common problem in developing countries. So if you have an issue where this door opens properly, this door won't open properly, the chamber will get more blood or less blood. What happens in that situation? Less blood. So what will happen to stroke volume in that case? Is it preload, afterload, or right? What happens? The preload will decrease. So the preload decreases, we already talked about this already, so if you had a drop in your preload, this is how much blood is supposed to come through that door, but if the door doesn't open all the way, then much less blood will come through. So as an effect, what happens is that the overall stroke volume has to drop. And this is a patient who will present with what type of problems do you suspect will happen here? What will they present with? They'll have probably not syncope, but they'll probably have a lot of dyspnea. Do you have any? Unless you guys don't answer because you guys are practicing. You guys answer. Why would a patient like this have dyspnea? Why would that be common, or in the back? Why would a patient like this have dyspnea?
Due to pulmonary effusion, higher pressure in left atrium than pulmonary circulation, and
yeah, exactly right. Exactly right. So any rise in left atrial pressure will result in transmission to the pulmonary circulation itself, which is where all the oxygen diffusion occurs. So if your lungs are congested from an elevated left atrial pressure, the exchange of oxygen is less efficient, so these patients will have shortness of breath. That's typically how they present. And this can be corrected quite effectively by dealing with the mitral valve itself. And because there's been no stretching of the actin-myosin situation, as soon as this is corrected, their left ventricular function goes back to normal, and they feel much better. Let's talk about